Mr. Chairman, professors. Each of us would like to simplify his procedure, but actually the size of the side branch and the complexity of the region would change your strategy, so you have to be ready. Our patient is 50 years old, male, diabetic, hypertensive, smokers, complaining of exertional chest pain with infralateral ECG changes, good LV function with segmental motion in the infralateral segments. The coronary angiography showed moderate atheroma in its middle AD with tight stenosis in the LCX involving the obtuse margin with no significant lesion in the right coronary artery. This is the best scheme for the lesions. So, how would you treat this tight stenosis? According to the what's published in the European Bifurcation Club, this approach for bifurcation using double stent technique based on the side of the side branch in comparison to the the main branch, the angle and the Medina classification. So, if the Medina classification is 111 or 101 with angle about 90 and the main branch proximal disease only, TAP technique or modified T. So if the main branch proximal disease with Medina classification 111 or 101 and the angle about 60 and the side branch equal the main branch, so Kilot technique, mini crush or D crush is the best. Are the best. If the proximal main branch more than sizable than the side branch, so mini crush or D crush is the best. No proximal disease with Medina 011, large proximal vessel, so V-stenting, simultaneous kissing or TAP technique are the best. So I decided to start with two-stage technique, XB 3.5, 7 French guiding catheters, BMW wires in the obtuse margin and the LCX. My estimation for this lesion is a soft lesion, so I decided to do direct stenting using Zions expedition 30 by 38. Then put for the proximal part of the stent. While we are doing both proximal optimization is very mandatory in two-stent technique to avoid the recrossing of the wire behind the struts of the proximal part of the stent. So I recrossed and opened the struts by using 2015 balloon. So I put a main branch balloon 3.5 by 15 and stenting the side branch using Zions expedition 30 by 15 with minimal protrusion in the main branch. Side branch stent deployment. And then I did final kissing. And I post dilated the distal segment using the NC balloon 3.5 by 15. And this is the final result. This showed the kissing balloons modified the angulation of the side branch stent struts protruding into the main vessel to create a small single layer, the new carina, as we see here. To ensure an optimal final result, the correct performance of the technique is more important than the choice of the technique itself, and this is what will determine the patient clinical outcome. Thank you.